Welcome everyone to today's webinar, Prepare for Launch, Best Practices to Prepare for Price Transparency. I'm Morgan Hafer with Becker. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it's now my pleasure to start today's webinar by introducing our presenters. As Vice President of Revenue Integrity and Chargemaster, Julie Roberts oversees and manages Chargemaster, Charge Capture, and Charge Audit reviews for Ensembl Health Partners. Julie brings over 15 years of professional experience to the table. After beginning her healthcare career as a project manager, Julie moved into various operational and IT roles within her revenue cycle career, ranging from academic level 1 trauma to community facilities. Julie has vast knowledge and experience using the EPIC system, including system installs of over 24 facilities in her career, and designing critical workflows for optimal revenue cycle performance. Julie's credentials include certification by the Healthcare Financial Management Association as a certified revenue cycle representative. In addition, Julie is certified as an administrator in EPIC's hospital billing module. Julie holds a Master's of Science degree from the Northern Kentucky University. Next is Emily Jones, Senior Vice President of Patient Access for Ensembl Health Partners. As an operational leader, Emily brings 17 years of revenue cycle experience to Ensembl, including 5 years in the physician setting, supporting more than 20 practices, and 12 years within the acute care and facility setting. She has managed patient access and pre-access functions for 14 years, including in her current role for multiple clients and more than 60 hospitals. Emily's prior roles at Community Health Systems and Health Management Associates include serving as Corporate Pre-Arrival Director with oversight of 72. Emily believes in practicing servant leadership by providing education, structure, internal growth, and proactive support to her teams. She leads through influence and collaboration, coordinating closely with back-end teams to identify issues and trends that can be mitigated within patient access. Emily holds an MBA with an emphasis in leadership and ethics from John Brown University. At this time, I'm pleased to turn the floor over to Emily to begin today's presentation.
All right, thank you, and good afternoon to everyone on the phone. I'm here with Julie, and we are so excited to talk to you about price transparency. And there's a lot of questions around this topic currently and a lot of commentary, so we hope to get some great questions from those of you in the audience. Certainly, while we're waiting on the final ruling to be made available, we can talk about what's proposed, but we may not have final answers until CMS gives that further directive. So for the agenda today, a few of the key things that we're going to talk through are the current requirements and whether or not you're meeting them, a brief readiness assessment, so based on potentially what would be required in the future, how ready is your organization, and then thinking forward, what are some key recommendations for staying ahead of the curve. So just a brief overview of Ensembl. I won't read all of these statistics to you, but one of the reasons why I love working with the organization and so many of our hospital partners is that we get a great opportunity to talk with them about what they're doing to stay as industry leaders or to work with them to become industry leaders. We work with a wide variety of different HIS systems, EMRs, certain system limitations, and so if you or your facility or organization is really struggling with we have technology limitations or we're just not sure how to handle a problem, chances are we can connect you with someone else in the industry or across the nation that can assist you in solving that unique problem. All right, get your mouse ready. We have a few polling questions that we would like just to get a base understanding of where you are currently and what are some of the items that may be required in the near future. So you'll have about 5 seconds or so to answer each question. And certainly you'll just be able to see the overall results. It won't necessarily be tied back to your organization. So question number 1 is, what percent of your patients are offered an estimate prior to or at the time of service? And you can see our answers here are 95% or greater, 80 to 94%, 50 to 79, and
you're not offering.
You're not offering. So I'm going to give just a few seconds to answer that and then ask Julie to go to our results. Okay, let's see what we have. All right, so it looks like the majority at 58% either are not sure what percent of the time that's offered or currently are not offering them. Julie, would you like to ask our next question?
Sure. All right. So are your ChargeMaster items easily accessible to the public today and are in a machine-readable format? You can select, again, this is current state based on the 2019 regulations. Let us know if, yes, they are out there in public, no, they're not, or you're unsure of that response. We'll see where everybody is at. So 61% of you guys said yes, you are and have your current ChargeMaster items accessible online to the public in a machine-readable format, which is great. 22% of you said no today. So we'll probably touch on that in a minute and kind of dive into that a little bit further.
All right, our next question is, do patients have the ability to price shop, generate estimates through a self-service portal, or receive electronic estimates? And again, our answers are yes, no, or unsure. All right. And it looks like about 60% of us said no, they are not, and about 20% said yes. Great. Okay.
All right, last question. How prepared is your organization based on the preliminary executive order that was published? We're giving you 3 options here, so think through these. Do you feel like you're mostly or fully prepared, somewhat prepared, or that third option, not prepared or even unsure of the requirements at this point? So take a couple seconds and let us know. All right, so based on the preliminary results, it looks like 51% of you say that you're not prepared or even unsure of the requirements, and 44% say somewhat prepared. There are some folks on the line, 3.9%, that says that you are mostly or fully prepared, which is great news, which really kind of dives into why are we here today and why are we talking about this very important topic. So let's talk a little bit about understanding where we are and where we're headed based on the regulatory items that are published today. So why price transparency? We all know we're in this industry and we know that there is a heightened awareness on price transparency because of consumer demand. And so we wanted to touch on some survey results from the Foundation of Government Accountability, some survey results that were published. And although I don't need to read this to you verbatim, obviously the goal, right, is from a CMS perspective, is to drive down healthcare costs. If you look across the globe, right, the U.S. healthcare costs are at the highest. And so we, from a CMS perspective, driving down those costs is top of mind, right? If you look at the survey results that were completed by FGA, there were a couple of things that's really important. One of which is that, folks want 82% want the right to know the cost of emergency procedures ahead of time, right? We all know that in those cases, there are some potential surprise billing situations that happens in there. And the process we're going through is to minimize that. 72% support the right to select a lower cost out-of-pocket network providers to kind of negate some of those costs from a patient perspective. But we also know that 2020 is an election year, and so there's lots of visibility into the topic of price transparency, healthcare costs in America, and those tactics and items that go into driving that to reform. And you may be thinking, she's using a lot of words that may be politically charged, but what's interesting about the survey result that was completed is that if you look at the demographics of the survey results from the Foundation of Government Accountability, is that regardless of party affiliation, regardless of age, and regardless of gender, the respondents to that survey are focused on driving down healthcare costs and getting more visibility into the healthcare cost of what services that's taking place in a healthcare setting. You can see there that the demographics, again, across the party affiliation, across the age divide, and as well as gender, all say the same thing, which is patients want transparency, which is why we're here today and having this conversation. Another, obviously understanding why we are here is that those things that I just mentioned before are driving a high volume of media presence. So this really goes beyond Washington itself, right? And really getting into our communities of what we are all doing in the healthcare space to make progress in this area. So you can see that regardless of if you are, somebody that tunes into Fox News or NPR or CNN, NBC, all of the media outlets are focused on price transparency and the recent executive order that was published, a few months ago. And so regardless of where you turn, right, at work or at home, this is a key topic that we will continue to hear about in the continuum of this topic. So speaking of continuums, let's talk a little bit about, if you're not familiar with, the 2019 Price Transparency Timeline and Current Requirement. So we all know that last year, as a part of the FY19 IPPS language, there was regulation that was added into that final rule that stated that all hospitals needed to disclose their standard list of charges for all items and all services in a single digital file that was machine readable. Now, if you were in this mix last year, you know that was published in November, and then in December, we had a clarification FAQ from CMS indicating some clarifications around their requirements. And it was at that point, at that FAQ, that we learned that a PDF was not acceptable. We learned that all items and services needed to be added, regardless of if they were, if you had multiple fee schedules, if it was drugs, whatever the services was, all needed to be included in that regulation. And so that requirement went into effect January 1. Fast forward, right, between January 1 and June 24th, we heard a lot of the news outlets, right? A lot of the conversation kept going about what is going to happen to evolve this topic. So on June 24th, some of you, including us here at Ensembl Health Partners, tuned into the executive order signing by President Trump, where he signed an executive order to give instructions to, right, instructions to government agencies to define several topics of how to push this conversation forward. What needed to be posted, who was going to do those actions, and what regulatory governing bodies were going to be involved. Not only price transparency topics came into play, but also regulations around the Surprise Billing Act, which had also gotten a lot of airway news space between that point. So from June 24th to the next kind of topic or point in time was August 9th. At that point, the Federal Register published those proposed rules. So many of you on the phone, again, including us here at Ensembl Health Partners, spent a lot of time going through the regulatory proposals that were put out. Lots of questions, right? Everybody had questions. What does this mean? How do we publish prices based on contractual rates? You know, at that time, it was very clear that CMS was aiming to empower the patients by requiring, you know, that public disclosure of rates negotiated by hospitals and payers. We knew that was coming. That was kind of a next step, again, in the continuum of this timeline. So fast forward again to September 27th, which was the cutoff date for the commentary period for the proposed regulation. Many of you guys who are providers on the phone should have taken that opportunity from the 9th to the 27th to really respond, right? Many of the state and local hospital chapters started getting some groups together and responding as teams. What, you know, their proposal, what are the things that needed to be pushed back on, what things needed to be changed. And so September 27th was that end cutoff date where CMS was no longer collecting feedback. And so we're in this time now between September 27th to the anticipated November 1st, 2nd, where we do believe that we'll get those final rulings with the commentary notices included. So we are just as anxious as you guys are to understand those final regulations of what's involved.
All right, and as Julie transitions our slide, is it true, Julie, that you watched the live streaming of this executive order announcement?
You know, I did, and it was very exciting because, you know, you log in and then it takes them about 10 minutes to get to the podium. So there was lots of time for folks to reflect on what was really going to be included in that. So it was fun.
Awesome. All right, so let's talk about what's being proposed through CMS for price transparency going forward. So please keep in mind, these are just proposed requirements. We will not have the final ruling until probably at least November. And then there is some speculation with all of the political activity that it could be extended past that time as well. So please stay tuned as we learn what those final rulings are. But as far as currently who's in the proposal, and you'll notice we'll provide you the link of where we're pulling this information from. The sites and excluded sites are listed here, so your critical access hospitals, community hospitals, psych and rehab. One call out I certainly want to make sure that you're aware of is that it also would include estimation for physicians and providers that practice within those sites. So as you think about your ability to provide cost estimates when your employed providers are billed out of a separate system from your facility system, those are things that you should really be thinking through now. From some excluded sites, we have the ASCs that are freestanding, other site of care, and then any federally owned or operated facilities. And CMS's comment around why, you know, Indians and VA and some of these other treatment centers are excluded is because these services are not typically provided to the general public, and the prices are not subject to negotiation. So that's specifically why those were excluded. So what then is CMS proposing actually be given transparency or visibility to? So majority of this will be around actual visibility to pricing, which we'll get into a little more detail about specifically what they're looking for there. And then individual items and services, or what they call service packages. So think about an individual item, maybe a charge master item like a CT or an X-ray or a lab, versus a service package, which may be more of a holistic surgery procedure or, you know, major joint replacement, something like that. And again, you'll see a reference here that it would include the services of employed physicians and practitioners within your organization. Within the proposed requirement, there is a minimum of 300 what they call shoppable services. CMS actually published 70 that they have defined, and we'll give you a screenshot of that here in just a couple of moments. And then the proposal is that they would allow 230 additional procedures or services to be selected by the individual hospital, and the recommendation is that you do so through a utilization report of frequently scheduled or shoppable services. Now, as we talk about what does CMS really consider a shoppable service, this is a service that can be scheduled in advance, and how you should present those to the patient is not some of those sometimes very cryptic CDM descriptions or even necessarily the full CPT code or DRG verbiage, but something that can be understood with plain language descriptions for the patients and easily searchable by either a service description, a code, and we'll talk about the different codes that they have listed, or individual payer. The shoppable service that you display should also include normal ancillary services that the hospital would customarily provide. So thinking about anything that your facility would charge for, specifically lab, radiology, drugs, therapy services, room and board, most of your normal things. But again, I want to call out those employed professional services because we see so many people that bill out of two different systems that it's critical as you're thinking about how you're going to demonstrate that cost estimate that you're thinking about those two things combined. On the list of shoppable services that CMS has published, the 70, if your hospital does not provide that service, then you would could list that and you would put an NA for that corresponding charge, or somehow make it clear you don't provide that service, and then you would just add an additional service onto your minimum of 230 for each service that your facility does not provide. So within the actual elements of how this should be presented, not only has CMS outlined that or proposed that you should be demonstrating and showing what that gross charge is, but also the corresponding payer-specific negotiated charge or rate for each negotiated payer. So stop and think about that for a minute, about how many negotiated contracts and contracted payers that you and your facility have. It could be hundreds, it may be thousands, it may be a payer master even that needs to be cleaned up. It could be several contracts that you have, and what's your ability to show those at a line item or a bundled package level. It could include inpatient and outpatient departments. And then from a code perspective, these are some of the codes that may be applicable that you would want to include on your presentation to the patient. So certainly CPT we're fairly familiar with, or any HCPCS code, DRG, NDC, revenue code. And the key here, which Julie hit on earlier as well, is that this file must be machine readable, which again means that a PDF document would not work. Or would not be accessible because it's not easily extracted, and you have to further process or format that for it to be machine readable. CMS actually had some commentary in the Federal Register that they had debated requiring all facilities to use the XML format. However, they did open it up to additional formats here as well, and they are or were seeking public comment on whether or not there should be a requirement for hospitals to make public their charges through some sort of open API. And essentially their commentary included there was so that patients could have a choice of apps to use. So think about an app on your phone where you could price shop, or you could easily find charges for facilities online.
So Emily, I'm just going to jump in that we have seen throughout the FY19 regulation that, patients were struggling with those that have published a PDF. Patients couldn't pull that file down. So it's good to see that there is conversation around multiple file formats, providing more guidance in that space, right, to be able to help the patients, one, access the content, and have it easily accessible to them to pull up. So.
Definitely. All right, so then from what's proposed as far as charges and amounts, again, CMS is proposing that you not only publish your gross charges, but any payer-specific negotiated charges. So think about not only your managed care contracts, it could be work comp, it could be, any organization in which you have a negotiated contract. And this should be published and updated at minimum once per year with a clear indication of the last time it was updated. So think about even once you publish that file, where in the file will you indicate the last date it was updated? You'll see in the box over to the right some of the things that were considered to be required but are currently not proposed. So if you think about worst case, maybe what will be in the final ruling or what could come in the future that isn't being requested today. So certainly volume-driven negotiated charges, the min, medium, and max for each of those services, all allowed charges, discounted cash prices, and then median cash prices. And then what is included in the proposal is that each hospital location would be required to host a separate identifiable list of charges. Now, some of CMS's commentary and why are they requiring all of this information to be published to patients, they felt like there was certainly value in posting gross charges versus negotiated charges because it would help drive competition. It could result in hospitals lowering their charges for what they consider the most, quote-unquote, vulnerable consumer. It could give them access to charges for what's been negotiated on their behalf by a third-party payer. And the reason that they're not requiring that you publish this for Medicare or Medicaid fee-for-service patients is because, in their opinion, these charges are not negotiated and are often already publicly available. All right, so then we have here for you, certainly this is not an all-encompassing view of a template of what may be provided, but if you think about some of the key components that would be provided, and certainly if you're going to provide this in an Excel format, Julie's going to talk a little bit later about forming an internal governance team and how you can work with multidisciplinary departments within revenue cycle to come up with how you'll provide this information to a patient. So we just started the basics of a spreadsheet type format to say, if you were to lay out all of these items across for all of your payers, then what does this really look like and how big does this single file truly become? So certainly you'll want some additional columns on here and some better plain language descriptions, but this is one of the key things that we would recommend that you start working on now is what does that template really look like for your organization. Here you'll see some proposed shoppable services that CMS included in that 70 required, proposed to be required services. And when you think about a shoppable service, for some of us, we may think right away of things that are normally scheduled. So we kind of tend to go right to that middle square here of radiology services. So mammos, CTs, MRIs, those are things that we immediately think of as shoppable. But you actually have a good list of lab and pathology services over on the left. And then even here on the right, you have more complex services that, again, we may think of as schedulable, but we don't always think of facility scheduling, basic lab and x-ray. We also don't always think of providing that all-encompassing charge and negotiated rate for surgical services, medicine services, E&Ms, those types of services that may be provided. CMS also documented some concerns on, as they were reviewing different healthcare organizations and how they had posted their charge master information, they documented some concerns on the accessibility of consumers. And I think several people out there certainly anticipated that just by posting a charge master was not going to solve the problem for patients to understand what their charges are going to be. So certainly those aren't negotiated rates. Those aren't typically what we would have as self-pay prices, and that can be very confusing for a consumer. So these are other items that CMS documented as concerns on consumer accessibility. And some of these include things like just navigating through the website. So actually finding the information and where it's housed, being required to click through several tabs and links just to get to that information. I know we've seen, Julie, organizations that have a pay my bill section, and then it takes 3 or 4 clicks to get to an estimated section. And it's just not intuitively where a patient would go to try to find this information, especially if they're in somewhat of a hurry, right? Like we're used to going to Amazon, we're used to going to Priceline, to all of these places where we can quickly, from a central location, find price information and get even good reviews about certain services that we purchase. And in healthcare, a lot of times we're just behind that from a technology aspect. So we're going to go through a few of these concerns and what is included in the proposal you will see here. There are 3 main things that are in the proposed requirements. So number 1, as far as being included in the requirements, would be that this information is displayed prominently. So the purpose of the web page and that information is clearly communicated. There are things like no reliance on breadcrumbs to help patients navigate, and that it's easily distinguished on the web page where to find this information. CMS actually had talked about that they were considering requiring in the future that hospitals all submit a link where patients could access it from a central CMS website. So think about that from a patient's aspect, going to CMS, seeing a laundry list of facilities to choose from and clicking that link and being routed back to the site. So as you are thinking through how you'll make this work for your organization, how do you set it up visually where the patient knows immediately where to go? How this information then is, number 2, easily accessible. So the information is presented in a format that can be searched by those items that we listed out earlier, and that it can be accessed with the fewest number of clicks. Number 3 is that this information is provided without barriers. So certainly that you're not charging any kind of fee for users to access this information. And here's one thing that's very key that I think several people are not anticipating. So part of the proposed requirement is that users should not have to enter any information to access this data. So currently today, you may have a self-service patient portal, you may have an estimator tool, you may have things online that the patient can use to access this information. But part of the proposed requirement is that these users would not have to enter a name or email or phone number or any of that type of information in order to get access to that. The other key here is that the proposal is that you must be able to provide a full paper copy to the patient or consumer within 72 hours of a request. So what does that look like? How consumable is that? Is it a brochure? Is it a booklet? Is it a pamphlet? How is it that you're going to provide that information to consumers on paper through within that 72 hours? So Julie, that is a long list of requirements of what's being proposed, and certainly I think most of us want to be compliant with CMS and want to do the right thing, but can you talk to us a little bit about what has CMS proposed for providers that do not follow these guidelines?
Sure. Yeah, Emily, I think that's a great question, and I think as healthcare providers across the country start to prepare ourselves for this regulation, one of the large components of this is that we are seeing that CMS will require monitoring in 2020 for providers compliance related to this statute. And so we knew in FY19, once we started hearing more and more, we knew it was going to build to this point. So I don't think a lot of healthcare organizations were surprised by the fact that in the proposal we now see that there is a civil monetary penalty for noncompliance. So Emily did a great job outlining what we believe as the proposed, right, as we kind of anticipate the final. What we are anticipating is that folks need to start to pull themselves together to have a strategy, an integrated strategy around price transparency to avoid these civil penalties. And so when we say civil penalties, what does that mean? CMS is going to have an evaluation process by complaints made by individuals or entities to CMS where they start to take action. They then will review the individual or entity's information analysis related to noncompliance. And the biggest thing is that the civil penalty is noted in the documentation as $300 penalty per day for noncompliance, up to $109,500 annually for noncompliance. And so when you think about that, some organizations may be thinking, oh, $300 a day, you see that, Emily, but we know that, we have clients across the country that could be, 15 facilities, 29 facilities, 50 facilities, and if each one of your facilities is non-compliant, then that's per penalty per hospital per day up to that maximum. So if you are a 15, facility entity, you could be impacted over $1 million of penalty cost, right? Those costs need to go back into healthcare to providing excellent service for our patients, right? New CT machines, new X-ray scanner, whatever that might take. So we cannot afford, right? Hospitals can't afford non-compliance at this point. So that's really something that we wanted to point out to the group and make sure that as you start to prepare, that there is a financial cost to this impact of non-compliance, as well as a patient expectation, right? We know, what we said earlier, you're seeing all the news articles and blasts about this information. So you have the pressure from your patient population as well as from CMS to drive to compliance. Mm-hmm. So as we talk about this, right, Emily talked a little bit about all the kind of structures that is being proposed. And we at Ensembl Health Partners believe that it's important as we have these types of conversations that we provide guidance, right, that we provide tools to help you in your preparedness. And so we will have in the next few slides some conversations about preparing for best practice recommendations and key considerations. In your resource list, in your webinar box, there is a readiness checklist that we have provided. There's also the slide deck that we're covering today is in that resource list as well. Pull these things down, right? We want you to leave here and have some actionable items that you can work through. So if you can get to your box and pull those down, I think that would be great. But let's talk about specifically some technology and tool readiness that we have outlined on the checklist, things that are tangible that you can start to consider today. Again, we don't have all the answers to the final rule because it's not published yet, right? But we know that you can take some action. So what are those things that you can take back and start to work on? The first is to evaluate tools and consistent use for estimates and contract management. So earlier, I think in the survey, some folks were saying, well, I don't really have a tool for patient estimates. We don't really, have that kind of moving for us yet. Things that you need to consider, right, is what automation can be utilized. How will you generate estimates for patients really without barriers, right? What are the things that we can do, your hospital in particular can do to generate estimates from your host system? Maybe if you have a platform that's not an integrative platform, then can you utilize a standalone tool? Absolutely. There are many vendors, great vendors out there that offer a selection of tools. If you don't have a way to generate an estimate today, you're going to need one. And so be thinking about what your options are from that perspective. Even if you have an Epic, if you're in an Epic shop, if you're in a Cerner shop, there's some requirements needed to generate estimates from that tool. And so starting now is necessary in order to meet the deadline of the January of 2020. Also considerations is how will you, how will payer negotiated rates be made accessible by the, to the public in the public format, for services that are not hard-coded in the CDM. There is not a one-to-one match for everything in your CDM to the negotiated contracts. We know that. We live and breathe this type of work. Right now, that's the world that we're setting in order to, meet the requirements. We need to think through that. And although that, we may not have the answer today, right, you need to be thinking individually in your organization, if this is going to come to fruition, how would we make that happen? Are our contracts updated in the system? Have we done a review of our contracts and our rates and our CDM, and do we feel like we have clean files today to work with in order to prepare for the final rule? Those are considerations you need to make. You also maybe need to think about a dedicated phone line or online FAQ section for patients. Emily spent a lot of time about the preparedness of the rule, right, about plain language, easily accessible. There are organizations out there today that are doing amazing things related to patient outreach, related to the, patient estimates, or how do I, right? Where do I find information about my prices? Some organizations are putting tutorial videos together. They're doing amazing things out there, walking patients through the format of where you find this, how do I get to it, and really what does it mean? Right? And where do I go as a patient to get more information? So there are some walkthrough guides, tutorials, videos. Think of small, quick webinars that organizations can do to drive more communication to patients. There's also some consideration and conversation out there about providing chat, text, or email support to patients on real time who are looking through your pricing documentation. What we don't want is patients to feel like they don't have anywhere to go to get information, right? Many organizations have put disclaimers out on that web page, that splash page, to say, hey, patient, if you need help, call us at this number. Sometimes patients can't call, right? They call in the middle of the day, they're working. A lot of organizations are thinking about a chat, text, email option in real time as well. So that's something to consider at this time. From an awareness and governance standpoint, we talked a little bit about this with Emily, is that we do suggest on your toolkit, on your checklist, to start to create an integrated strategy group, a cross-functional team in your organization who are going to have all eyes and ears focused in on price transparency for your patients. And when Emily and I have been a part of these internal governance councils, it's really important that you think outside the box, right? It's, of course, your CFO, contract management, compliance, revenue cycle, but also think about your marketing teams, right? If you want to do something that's progressive in a video or chat, or you need IT to come to the table, right? You need your EMR team typically to come to the table to help you provide a robust view. Don't put yourself in a box by not inviting a champion from those teams to the table, because we always say at Ensembl, revenue cycle is a team sport, right? And so open yourself up to those with those perspectives as well to, again, provide your patient with the best options. You also need to deem who the price transparency owner or champion is. I think, this is a topic, and Emily and I have had these conversations, across the board about who is your champion, right? And a lot of times it's, well, compliance is doing one part and we're doing another part. We believe that you need a singular threaded champion to drive those changes from a strategic perspective, to allow your organization a holistic approach. Then get those key stakeholders on as an overall governance group. We do encourage coordination with managed care. Obviously, the requirement, right, of those negotiated rates is key and critical right now. That in our mind still is yet to be determined, right? There's going to need to be some rigor. CMS already has said in some publications that they've received a lot of feedback, right? We are waiting for that feedback to say, how are we going to do this? But getting around the table and having those conversations today about what's ambiguous about our contracts today, right? What are we going to do with hospitals with multiple fee schedules? Start talking about that file format, right? Looking at it through a lens of patients. Some organizations that we've talked to have said, you know what, Emily and Julie, I think we're going to do some focus groups. We're going to get a wide range of demographic patients to come in. We're going to show them some options in terms of navigation and get some feedback from there. That's a wonderful idea in order to prepare yourself for the future. Moving along in conversation there, we do want to talk about communication and education. So, ensure when we talk about communication and education, we want to make sure that you guys think about internal and external communication. I know in this conversation we've talked a lot about how are you going to educate and communicate with our patients, which is key, absolutely key and is critical. But please don't forget internal communication requirements, right? That governance council can help disseminate key information through alerts or whatever if you need to get information down to staff. Obviously, you think about our pre-access, patient access staff that's having that conversation with patients, who's answering the phone in customer service from a self-pay perspective. Those are the folks that we have to educate and train and be ready for in advance of 2020, right? What we don't want to have happen is you guys make some decisions and not communicate internally to ensure that we have that disseminated down. Patient education and experience, we talked a little bit about this, is ensuring that you have an option for patient outreach. Again, town halls and focus groups are a hot topic right now. We've attended many sessions where some providers are saying we're definitely going to do these town halls. We think that's a great idea, but that's work that you have to do now and not later, right? Doing that kind of mid-December is going to really put a strain on your internal resources to ensure you're compliant. So think about the timeline of that. Obviously, presenting information in an easy-to-read and understandable format is top of mind for all of us, right? When you talk about negotiated rates from a contract perspective, we've all read many of those contracts, and so it's important that we make sure we present information to patients that's easily accessible and understandable. Obviously, always remember that this process is confusing to patients. Emily and I have had conversations about our own, family members, right? We all have family members that are superstars, right? The wizards that can go find anything on the internet. We also have those family members that struggle, right? And so how do you meet in the middle to make sure that your information that you're providing is not overwhelming and confusing, again, that's easily understood in an easy-to-access format. So again, we encourage you to pull on that resource list, the checklist, and use that as a guide, right? Again, we believe every time you invest time in these webinars, that it's really important to have actions come out of it. And so, Emily and I are a part of some of these across the country, and we're really seeing amazing conversation happen in this space that are patient-centric, even though we don't quite understand all the final regulations that is to come in November. So we would encourage you guys to, think about the things that we've said today and use that checklist as kind of a guide to start those conversations internal. So we'll pause there for just a second. We have received a good amount of questions, and I know on the next slide on our deck really is our faces, so you can see who we are as we answer the questions. We have several in here, and I know we have about 10 minutes remaining. So I'll ask the moderator to go ahead and open up to some of the questions that were submitted.
Awesome. Thank you guys so much for that wonderful presentation. So let's just go ahead and dive right in. This first question here is for both of you. So how do we determine the list of shoppable services we will post for our organization?
Yeah, I think that's a great question. So Emily had defined what we believe will be in the final rule, right, about the number that CMS is going to suggest. And then we will have a plethora of, shoppable procedures that you can post for your organization. I would say data is where you need to start. So if you have a decision support team, if you have a revenue cycle analyst group, Emily talked earlier about leveraging, what are the commonly shoppable procedures, those procedures that are scheduled the most often, right? We want the list to be a usable list, right? Publishing procedures that, aren't shoppable or aren't frequently used is not where you want to be. So looking at how frequently those procedures are utilized is key. What are commonly scheduled? You can get that out of your HIS platform typically. You can use decision support personnel or revenue cycle analysts to evaluate volumes. And you would really want to look at that per facility, right? So if you're an organization that has multiple facilities in multiple regions, absolutely these regulations are at that kind of hospital level. So make it pertinent to your particular market is definitely key. Also, one of the other considerations that I think is important is that don't be constrained by the number that's published by CMS, right? If your organization, if you look at the data and it tells you, hey, I really should probably publish these 200, then let's do that, right? It's about your patient population needs and ensuring that you get good viewpoints from that population that's out there searching for that shoppable procedure.
Yeah, Julie, that's actually a great point, and I'll just tag on to that to say even in CMS's commentary, they talked about how 300 services is really going to be the minimum, and that they plan to expand that in the future. And truly, if this is a patient-focused effort, we would want to provide as visibility and access to as many procedures as appropriate.
Absolutely. Thank you both for diving into that question. And we are just getting a ton of feedback from the audience today. And I know one audience member is curious about some of the types of facilities that are included on the list. They are a hospital, but they're not a critical access hospital or a sole community hospital. And so they're curious, would they be required to meet these rules?
Yeah, I think the best answer here, and I'll let Julie correct or tag on, is if you're really unsure where you would fall on this list, is to coordinate closely with your compliance and legal department and let them help vet that out for you. I know there were questions like this and then questions such as, well, what if in my payer contract I am not allowed to share my payer negotiated rates? And CMS has even given guidance in that perspective that really needs those types of questions we would route through your legal and compliance groups because they'll know your situation most specifically. Julie, would you add anything?
No, I think you hit spot on, Emily. I think it's really important, again, to think about, if you're at a facility that you're not quite sure, again, this has to be a team effort. Get on the phone with your compliance and legal group, get the designation of your particular location, and then make decisions from there is your best route of approach. And doing this work now, I think that's a great question, right? Because now's the time to ask those things versus in December, right, when we're all trying to work towards the final regulation. Great question. Thank you for submitting that.
Great. Thank you both for your insight there. And we have a question in particular to slide 19. And it's about that penalty for not meeting this proposal. So an audience member is curious, what if it's one corporate charge master for a group of 10 hospitals? Is it still going to be that $109,500 penalty per hospital within the system, or was that system-wide?
It is our understanding, and I believe this was some of the feedback that we had heard from providers, that we need clarification in that space. Right now, it's per hospital for non-compliance, the $300 penalty per day. I don't have a crystal ball. I'm not sure if we'll get clarification on that. So I think we need to assume right now that we stick with the assumption that it's going to be per hospital for noncompliance. They will be doing some heavy monitoring. We do know that. And it's just a risk that, none of us want to take, right? So let's look for the final rule to give us some clarification on that. But today, as we understand, it's per hospital.
Interesting. Thanks so much for tackling that question. The next question is more about service packages. An audience member is wanting, in service packages, when you consider supplies, do you need to show the different prices for different vendor implants? They give the example of a total joint vendor implants might be different by sometimes hundreds of thousands of dollars. So do we have to show the price after any rebates and share back?
Yeah, I think that, again, is going to be another one of those things that we're going to look for clarification on in the final rule. We've heard from healthcare organizations across the country about some of their feedback, and the entire topic about supplies and those high-dollar implants, right, is key. We don't quite know yet where we're going to land on that. So, again, I think that's something, unfortunately, that we're going to have to say today. We will be waiting for that final rule on that piece of clarity.
Excellent. Another audience member is curious about the proposed minimum of 300 shoppable services. And so they're curious, if a hospital does not currently have a charge code set up that is in the list of CMS's 70, can they choose another code that adds up to the hospital's 230?
So the way we read the Federal Register is that if your facility does not provide that service, that you would indicate NA or service not available at this facility, and then yes, you would supplement that with, you would have 231 of your own elected services versus having only 230.
Got it. And how does this rule apply to contracted but independent medical groups? So does a contracted but independent medical group live under the price transparency rule? Example, medical directorships or coverage contracts.
I think in that case, we would ask just for firm clarification, again, with your legal or compliance group. This is mostly, as of right now, focused on facility, although you can see that certainly they're including some employed physicians and employed non-physician providers within that. I did not see anything that was specifically called out for medical groups, or what I would affiliate with that is professional services outside of that. But again, just to be sure, I would route that through legal or compliance at your specific organization.
Absolutely. Thanks so much for answering all of these questions, and definitely a lot to be learned yet. And we have time for about 2 more questions, so I'll answer this, or I'll pose this audience question. They ask that you mentioned at the beginning that consumers are demanding price transparency, but they note there's some research that says when patients are given price transparency tools or price comparison tools, they don't use them to their intended purpose. So why do you think that is?
So I'll start with that and let Julie tag on. I think certainly I can't speculate on an individual person or why someone may or may not use a tool. I will tell you or share with the group, things that we see on a consistent basis is that this process is very confusing, right? So even some of CMS's concerns are valid. First of all, how do I even find the estimation tool? I've looked at several different organizations, and even as an operator have a hard time locating where I would go to find that information. The second thing would be, do I know my benefit information? A lot of times if we think about our registrars and our pre-access teams and people doing the work, some of them aren't equipped or trained to their best capability to understand it, much less for a patient who's not revenue cycle driven to be able to understand that. So I think ease of use, ease of visibility and finding it, and then again, that overall education to walk a patient through how they would do that. It's much more complex than posting ChargeMaster online or giving them a tool to sign up. Julie, anything you would add?
Yeah, I would just want to add the fact that when this came out for FY19, right, organizations looked at this and said, well, I'm going to be compliant with the minimum data set, right? And so a lot of organizations posted a description and a price, right? And so when patients go out there, they don't know what they're looking for per se. What is it called? The common, medical language is not common to them. So, we did see an opportunity to do some, patient outreach communication to help them through that process to increase the visibility of using those types of tools. But we know that this is a continuum, right? We're having this conversation today. In November, right, we will have additional conversations. And to be honest, this one regulation isn't going to solve all of our patients' needs. We know that, but we are all committed to getting us there through the iterative process, which I'm excited to be a part of. I know Emily is, and I know many of you are as well, to make U.S. healthcare understandable to patients who are consuming that on a day-to-day basis.
Absolutely. Thank you both for giving your insight there. And that is bringing us to the top of the hour now. So I'm going to ask Julie and Emily, do you have any final thoughts before we wrap up today?
Yes, thank you. And I know we're running a little bit over, so appreciate everyone hanging on for this opportunity. The last thing I would say is that, really as revenue cycle becomes more and more complex, the stronger we will be through better collaboration. So please don't hesitate if you have a question or a unique challenge or things that maybe aren't necessarily legal or compliance driven, but more how to operationalize it, right? Like how to provide the information, how to provide education to the patients. What are other hospitals doing that are on your system or in your area? Julie and I, we love to talk about revenue cycle and patient access and
all day.
CDM. So we are happy to either have conversations or connect you with other people in the industry that we know that may be able to help you as well. Alternatively, if you have great ideas or your organization's doing something great, we also would love to hear about that and be able to share that with others who may need that additional insight and help. Julie?
No, we just appreciate the opportunity to talk to you guys about this. Again, like Emily said, this is a hot topic that we're all playing this sport to get to that end result, which is allowing patients a very understandable approach towards pricing and price transparency for healthcare. So thank you for giving us the opportunity to talk to you guys today. I know we had several questions that remain. So we will work with the Becker's team to get those answered and get those out to the group as follow-ups.
Well, just great. I want to thank you again, Emily and Julie, for your excellent presentation on this really important topic today, and also thank Ensembl Health Partners for sponsoring today's webinar. So please enjoy the rest of your day, and we look forward to having you join us for future webinars.